Hello, everybody. Welcome to another edition of AFR's EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire. And today I am joined by Captain Rob Laprice. And we're also joined by Lieutenant Chris Cruz. Welcome.
Yes, thank you.
Hands down, two of my most favorite people within our division. So I'm gonna talk highly of our EMS division staff here. Thank you for joining us.
And our favorite chief.
Oh, you're just saying that because I'm here, but flattery will get you everywhere, I assure you. So, Chris, thanks for coming to talk to us about this call. This was, you were assigned to Rescue 17 at the time, and you had responded to a 31 Delta, and it sounds like the information initially was it was for a 48-year-old female who was not conscious but was breathing. 31 Delta is a pretty regular call that we go to. However, they typically have a high propensity to develop into cardiac arrest. So talk through with us on some of the things that are going through your head and how you prepare before you arrive.
So yeah, it's pretty much what you said, Chief. I mean, if she's unconscious, it could have really been anything, usually probably something serious, right? So at 48, not a lot of info just on dispatch, right? So just thinking, okay, well, let's see if she really is breathing. Like they say, it's important to get like the history from someone who's there. I couldn't even be familiar with the address per se because it was support fill, just flown in on 17. So I didn't really, based on say even like the neighborhood, I didn't really know what to expect. Just going to a house and hoping for the best, really hoping it's one of those things where like, okay, well, it could be a host of things based on the history we're given and what we see, but let's just see.
Yeah, absolutely.
Yeah.
So we'll fast forward to you arrive on scene and you make that first patient contact. Tell us what you see and what you did initially as far as your actions.
I'll tell you, even before we saw her, as we're getting out of the rescue, alarm came on and actually advised that they're giving instructions on how to do compression. So basically let us know when you make patient contact what you see. So already we're thinking, all right. Luckily, because it was a 31 Delta, we had plenty of manpower. The engine was right behind us, right? So we walk in and we get waved all the way to the back of the house. And there on the floor in the back bedroom, we see the patient and she's already on the floor, but of course squished between the wall and the bed. And her partner is there doing manual compression. So the first thing, obviously, is to just pull her out to a more spacious area, really confirm that there's no pulse, and then basically just take over. And, once it was confirmed no pulse and we are working this code, if there's anything we didn't bring in, let's make sure, send people out to get it, right? And also, I tried to get on the radio to advise alarm room, this is a 9 Echo, please dispatched 7-8, and I also wanted to make sure 5-5 knew because they were coming in. Turns out my lapel mic wasn't transmitting, but luckily 5-5 was there pretty shortly afterwards, so we were okay on that.
Awesome.
Yeah.
Partner doing CPR, you were able to pull the patient into an area where you could work a little bit better. Was the partner able to elicit any history as what precipitated this and how that all went down? So
he said that it was only basically 10 minutes prior to our arrival. He said they were watching TV, and the words he said was that, quote unquote, she kind of just seized up and collapsed. We did try to ask just real briefly, any drugs or alcohol, because, that was always a consideration. Because I remember, for it to happen so quickly, I mean, she was already pretty blue in the face is what I noticed. But denied any drugs or alcohol, and then denied any kind of medical history. And I think a couple people had asked, because things, were getting kind of hectic on scene, so there were a lot of repetitive questions, but he was pretty consistent in just denying drugs, alcohol, denying medical history.
And when you found the patient, she indeed was in cardiac arrest at that point, so no pulse, not breathing at that moment.
Yes, sir.
Is that fair to say? Okay. And Cap, we hear this a lot right upon dispatches. Obviously, the information that the alarm room gets that's the best information they can provide to come up with the coding for the call. So a lot of times we'll hear 31 Deltas who are actually 9 Echoes. We'll have 12 Deltas, a lot seizure calls. Talk with us a little bit about that seizure that a lot of people talk about seeing before it precipitates into an arrest.
Okay, yeah. So cardiac seizures, can be before an arrest or even after an arrest, like a ROSC. And we're not used to seeing them because most of our arrests are fairly significant downtime or whatever, and they've been down too long for this. But our zero downtime arrests and our witness arrests, a lot of times we see cardiac seizures where they might tense up, posture up, have a seizure, and we think they're having seizures, and we look at the monitor and they're in VFib. So at that point, you just do your ABCs, make sure they're pulseless, and believe what you're seeing, and you defibrillate them. In addition to cardiac seizures, we can see anywhere from moaning, groaning, blinking, grunting. I've had people pull their own ET tubes out post-arrest. So all these things make it a very dynamic and rewarding call as paramedics. You know, I always say, you know, the fire department's a tax-based system. Well, one of the big ways we give back is these witness arrest and zero downtime arrests. Greatest cases ever, and we have the biggest impact.
Definitely, especially young patients at 48. That's typically our best outcomes and our best opportunity at that.
Absolutely.
So I agree. Dispatchers do a great job with those pre-arrival instructions. That's likely why the partner was able to start those compressions early. So we'll fast forward now to when you begin your care. Talk about some of the treatment and the things that you set up initially for this arrest.
So right away, the priority was to get the pads on so we could see what we were working on. The pipeman jumped on the chest right away, started doing manual compressions because the Lucas just wasn't like readily available with us right then and there. Metronome, the whole thing. And I think initially it was just kind of opening the airway and bagging. And I think even then we were still trying to check, you know, can someone check pupils? We were still wondering, you know, like, how did this happen? How are you like watching TV and seize up and then you go down? So really just a BLS airway at that point. By BLS, I mean even just bagging, you know, it wasn't an LMA yet at that point. The manual compressions with the metronome and getting the pads on. At that first pulse and rhythm check right away, there was still no pulse, but it was real obvious course VFib. And we were, you know, pre-charged already, so cleared, shocked right away at the 360. And now we had a minute, right? So now we're bringing in the Lucas. The rescue driver got a line right away. We were starting to pull up the epi, the antiarrhythmics. I wasn't keeping as close of an eye on the airway because I wasn't hearing that there were any problems. So that was fine. But then when we got to the second pulse and rhythm check, and that's when we were going to coordinate and put the Lucas on and go from there, she already had a pulse. And, you know, the rhythm was, it was rapid, narrow, organized. So all of a sudden we were already in ROSC, and we just had to pivot and go from there.
So at that point, did you guys have any airway established, or were still basic BVM measures?
Just basic BVM. I think there was an NPA
Awesome.
at that point, yeah.
All right.
Yeah.
So that's great. So one shock, and then we went into a more organized rhythm. We had palpable pulses, which is the best outcome ever. But you see it regularly as the 7A, right? We get that initial ROSC, and what is your direction to cruise on scene as soon as you see that?
I'm glad you asked that, Chief. Well, anything with a pulse is 100% better than where we were. Agree? So my direction is always, let's slow it down, let's get some things done, let's get some hemodynamic numbers in, let's get a blood pressure, and let's not jump to do anything with whatever post-ROSC rhythm we have. Because a lot of times we get tachycardias, rapid AFibs, they look crazy, and as paramedics we're taught to do what? We're taught to see and treat. But now's the time to just back off for a minute, let's just get organized, slow it down. That's what I like to do.
Perfect. And that question does come up a lot because you'll see that initial rhythm maybe jump into what we're calling like an SVT. It's super rapid. People want to address that right away, but giving it that quick 30 seconds to a minute to let everything reset.
Absolutely, because they've usually had epinephrine stuff, and they're hypoxic and all this stuff, and their acid base is screwed up. So I think it's just a time to chill. We're better than we were, and then let's, as a group, address whatever we think we want to address.
Perfect. Did you see any of those changes that you precipitated into that normal organized rhythm, probably a generally normal rate? What was your steps after that once you had achieved ROSC?
So definitely, so, you know, while we were getting ready to move her, got the 12 lead, got a good pressure. And this was, again, we hadn't even had a chance to give epi. I mean, this was all just on her own. The one thing that jumped out was that she wasn't satting very well. But the first thing we noticed was that we had run out of oxygen. So, okay, let's switch out the bottle. I mean, and that, and then the Mega Mover was there. So now it's like, are we going to take a minute to drop an Airway, or are we just going to get her at least into the back of the ambulance? Right or wrong, we decided let's get her back in the ambulance. Now, one thing we noticed, and I've told this a couple times now to people who have asked, like, even when we got her on the Mega Mover and picked her up, somebody said, did she just grab the side of the Mega Mover? And we all were like, no, we just thought maybe we got it hooked in between her fingers on her hand. We just didn't trust that she could be so, I don't know, vital so quickly, right? So we thought that was just us. But once we got her back into the ambulance, we saw that she was now satting well. Now that we had high flow O's, just bagging again with just the NPA. So we made the decision at the time, well, then because if she really was starting to come up, like, are we going to drop an Airway, or are we going to just, if she's doing well, we'll stay with that. We had the line. She was actually rapid and irregular at first. We're pushing the fluids. She normalized. We did start to see on the 12 lead she had some elevation. Okay, we're on the way to the hospital. So at that point, it was just like stabilization, cold packs, stuff like that. We did notice when we applied the cold packs, we're already en route, right? When we got the cold packs, that's when she moved, and I thought again that she was starting to come up more because of just the cold. But then it became clear to us that maybe it wasn't purposeful. I thought that she was posturing. Later on, when Cap and I debriefed it, he explained to me that it was likely a cardiac seizure. But luckily, it's not just me in the back of the ambulance. It's me. It's my driver. It's the AS medic. And he was actually the one who snapped to, like, let's push for SED if she's, like, seizing. And so he did.
Nice. So we did push for SED to kind of calm some of that tensing, that what started as purposeful movement but now looked like more non-purposeful kind of seizing up.
Seizure. Yeah, that's what I would. You guys did an excellent job treating that.
And good response to that. When you guys got to the hospital, otherwise that seizing had stopped, otherwise stable?
Yes.
Okay.
Yes.
And we obviously were able to get some follow-up. The patient ended up completely neurologically intact, which is fantastic. There was a long QT that was noted on her EKG, which could be potentially associated with the cocaine use. I know they said that wasn't the case initially. We don't know for sure. There was a positive drug screen for that, so it is a potential that that's what precipitated. We've talked at length at the last few case studies in regards to cocaine being more prevalent on the streets. Now we're seeing less and less fentanyl, but more and more cocaine cases. And although that's not going to change our course of treatment when that patient is in full cardiac arrest, but there are things that we can do to help ease some of that prior to them going into arrest. You guys did a fantastic job. The EEG was negative for actual seizures, and the cardiac echo looked normal, so it's just found to have that long QT, and the patient was given MAG after the fact. So fantastic outcome. I mean, we talked about lots of things can cause that long QT, but cocaine can do it too, so it's something that we have to rule out. So you did a great job of inquiring and trying to get some more history as to what would just cause an otherwise healthy 48-year-old person to just go immediately into cardiac arrest.
Because that's how you started off, saying she's 48, and now this is like the follow-up provides you like a full picture, big picture of what probably happened.
Sure. That we couldn't have known on scene because we asked and nobody was willing to admit.
And all these amphetamine drugs, whether it's cocaine, whether it's meth, crack, all this stuff is unpredictable on cardiac tissue. You don't know what's going to happen. It's unpredictable with the human body. People can have a stroke, they can have an MI, they can go into sudden cardiac arrest. So you just don't know.
Fantastic job, Chris, by you and the crew. So in retrospect, for our newer paramedics and our new basics included, what advice would you give, things that you would do differently, things you would do the same, things that went well from this call? What did you take away from it?
I don't know. Who knows how it would have gone down differently or if it was right or wrong. I wonder, we could have been a little more aggressive with the Airway sooner, because when she did do what I thought was posturing, we were like, well, it was one thing for us to say she was satting well with just bagging before, but now we need to secure an Airway, right? And then by then, when we went to go for an Airway, because she was tensed up, we couldn't open her mouth. So there was a lot of regret there, right? Because honestly, even if we had dropped an LMA, if she started to come up, we could have just pulled it if she had started to bucket. So that's definitely, looking back, that's something I might have thought to do differently. If we thought about it, then maybe we should have just done it. I guess it was good to hear, to just talk about cardiac seizures, because prior to the debrief, I had never even heard of that. But when you explain it to me, it makes sense, because, we were en route to the hospital and we were like, oh, did we miss, when we thought she was posturing, my gosh, did we miss some kind of trauma? Just double checking everything. No, there's no head trauma. There's no obvious trauma. So that's not it. So yeah, I would say just if you think to do something, and there's no reason not to, just go ahead and do it, because you can always change tack somewhere down the line. Like, it was what it was. Just kind of trust yourself in that.
Absolutely. And this is a fast pace. This is a dynamic call, right? You didn't go in expecting an arrest. You found it was an arrest. You had a pretty quick ROSC, so you're kind of working all of these things out in a condensed time frame. So I don't think there's any right or wrong. You guys were doing a great job handling the BLS airway, and then the cardiac seizures that we were seeing after the fact. You guys addressed that too. So it's great to be aggressive with the airway early, but if what's working is working, then there's no need to go beyond that. Do you agree?
I totally agree. I'm just thankful I was involved. I was clearing an arrest. I saw you transporting, and I knew it was you. I called him, and I got involved in this great case. To be devil's advocate with this airway, I wouldn't beat yourself up on it. Wonder if you're dead set on that airway. You think it's so important. You do it. Wonder if she vomits all over. What then? And then it could go either way.
Sure.
And it's a witness arrest. You could always do BLS airway, suctioner, and be fine. Do no harm.
Absolutely. For the month of December, looking at the stats, we had a 37% ROSC rate, which is fantastic. It's off the charts nationally. Nobody really even comes close to that for the most part.
That's great.
But, however, the patient who's walking out neurologically intact, I think, is the ultimate marker. So if you even have one of those cases for an entire month, and this month we've had several, I think that's really where it shows the worth and the care that you provide. That's clinically excellent to get somebody to walk out of the hospital after cardiac arrest intact.
Excellent care. Those are the cases we have to be on the numbers when we can't delay. Like, we have to be real paramedics and no goofing around. And you did that, and you saved her.
Yep.
Well, it was something else. It's good to hear.
Yeah,
Yeah.
you did excellent.
It was fantastic. And I appreciate you taking the time to come and talk to us about the call. Great case. If anybody has any additional cases that they would like to share, we'd love to hear about them. We have the tab in SharePoint that you can make a submission, reach out to anybody in the EMS division to let us know. If you're not comfortable coming to talk about the calls, that's okay. We can still talk about them here to get the message out, because we feel this is the best way to incorporate training, is to hear the folks who are actually doing the job, what they're seeing, what they're doing, what they would do differently, what they would do again. So I think that's where it's at. So all that being said, reach out to us, let us know if you have cases. And until then, we'll see you next time. Thanks.